You know, there's a very complicated interplay between our societal beliefs, the resources we have, our clinical knowledge, and even our personal priorities. All of those have to be taken into account as we prepare for taking on some new responsibilities. One of the programs that's been very helpful throughout the country is mental health first aid. We have more and more organizations that are using those when they onboard new people, and also for refreshers for members of their organizations. I think that one of the things we've seen time and time again is that people are not comfortable talking about mental health issues, even though they realize they're important. And a program such as this can really help people get oriented and get more comfortable with the new responsibilities. It helps them deal not only with their personal concerns, but also with some of the social stigma they've grown up with. And finally, it helps them deal with clinical worries. How are they supposed to help people? It's kind of similar to suddenly bringing obstetric patients into your medical practice. Everyone's going to need some refresher and some help in understanding what their special needs might be. Next slide. Luckily, we have a lot of help in understanding how to put together these teams. The AIMS Center, which you'll hear about frequently today, has done a lot of research in trying to understand what should be a collaborative care team structure. In addition to the people we work with regularly in our offices, our nurses, our clinical assistants, our staff, our data people and billing people, we also beginning to realize we need some kind of care management. And if we're going to deal with mental health issues, we need some backup for the care manager and the primary care team by a psychiatric consultant, in the same sense that we need backup if we're going to, with a cardiologist, if we're going to ask people about their chest pain and shortness of breath. So team building is a very important part of preparation in the practices you work with. If they don't have well-functioning teams, adding more responsibilities is not going to improve matters. You need to kind of slow things down and say, let's do some work on building your teams. The next thing that you're going to want to have in your practices is a method of problem solving. We like the PDSA structure. It's very intuitive. And just to give you an example, at our Family Health Center, we decided we wanted to do universal screening with the PHQ-2, which is a 2-question depression screen. And those of us who were physicians said, well, that's something we have to do. That's a physician kind of thing. The trouble is we only did it about a third of the time. So at the end of our PDSA and its failure, we listened to the clinical assistants and nurses in our group, and we handed over responsibility for that screening to them. They do that over 95% of the time, and they've been doing that now for almost 10 years. So having a way of solving problems based on evidence rather than intuition is an extraordinarily important capability for your practices. Next slide. The other thing you need is a way of looking at workflow. This particular approach is one that we've used successfully, where we try to work with, we put everybody in the same room, and we try to look at an episode of care, really starting before the visit and ending after the visit, and asking people, well, what is the work to be done? And once you decide this is the work we have to do to give good care, then we can begin to ask the question, when should it happen and who should do it? Very often we start with who should do it instead of what's really necessary. And we end up with care processes none of us like very much. Once you've got a picture of the care in your office, you can begin to look for opportunities to change it. You can, since we use a lot of lean techniques, we do a lot of observation where we actually measure the time it takes to accomplish a lot of these tasks. That's very important because the first thing that your staff is going to say, well, we don't have time for that. And you're going to have to find some time. It turns out there's a lot of dead time in visits, people waiting. And there are also new opportunities you can take advantage of in between visits. In addition to being able to look at the way care can work, you need to have some tools to optimize your data collection. Now with the EHR and the increased expectations for data, we can see we're spending a lot of time doing that, and we'd like to make it as efficient as possible. so that you have EHRs now. Almost all of them have a patient health questionnaire, PHQ-9 for depression screening. Most of them will allow you to even see how people answered over time, so you can get a sense of how they're doing in the same way that you would look at a graph showing blood pressures or hemoglobin A1Cs. And all of you have templates that can make the entry and follow-up of symptomatology and other issues rather simple rather than long dictations. And finally, once you've got the data in your system, it's very important to be able to get it out. This is a display used in one of our registries in the Compass program. It's basically a flow sheet that allows you to see the patients in your caseload, see the ones who aren't doing well, see the ones who are doing well, and to be able to focus your activities. All of the demands on our practices require us to begin to do risk stratification so that we can actually begin to make the best use of our time.